Daniel discussed the approach of a child with short stature, and now we will move and focus on the treatment for specific indications. So, growth regulation can be divided into three parts. In childhood, in infancy, growth is regulated mainly through nutrition. It's only in the second part, childhood and puberty, that growth hormone and 6 steroids play a role. So, for the rest of our talk, we will discuss this part of our lives. So, when discussion short stature, recombinant human growth hormone is the primary treatment for growth hormone deficiency, induced short stature, as well as the associated abnormalities in body composition, metabolic profile, exercise capacity, and quality of life. So growth hormone does not only play a role in growth, it's an anabolic hormone with multiple effects for the whole body. Challenges to effective treatment include difficulty in establishing a firm diagnosis of GH deficiency and the variable responsiveness to growth hormone within the population diagnosed with growth hormone deficiency. So how is the diagnosis of growth hormone deficiency made? Growth hormone is secreted by the pituitary in a pulsatile pattern. This means that a random measurement of growth hormone is of no value. A diagnosis of growth hormone deficiency is made when you have an insufficient growth hormone response on two different provocative tests with a peak of growth hormone of beneath 7 nanograms per ml. So, in this talk, we will discuss growth hormone treatment, but as you see, growth hormone is not only given for pure growth hormone deficiency, it's also recommended for other indications. We will discuss all those indications. It's also used for children with chronic kidney disease, but this is beyond the scope of our presentation. First of all, growth hormone deficiency. Those kids have a peculiar face with frontal bossing, saddle nose, and midfacial hypoplasia. As discussed already, we can define the hormonal diagnosis by performing two different growth hormone stimulation tests. For a good growth response, of course, epiphysis should be open, and important, the growth response is better when we initiate treatment at a younger age. As already mentioned, growth hormone is produced by the pituitary in a pulsatile pattern. The first growth hormone deficient patient was treated in 1950 with growth hormone extracted from cadavers. Of course, this meant that there was a very limited availability of growth hormone. Some patients treated with human pituitary growth hormone developed later on Creutzfeldt-Jakob disease, and this was a reason to withdraw this product from the market. Luckily, almost at the same year, in 1985, recombinant DNA-derived human growth hormone was being available, so there was no more problems with availability of the product. And then, step by step, other indications were also allowed for treatment with growth hormone. The growth hormone is given subcutaneously with a device similar to that used for children with diabetes. It's given subcutaneously once daily, and the treatment can be given by the patient himself from a certain age. A treatment of growth hormone is very costly, with a daily cost of 25 euros a day. So reimbursement criteria are implemented by the RECIF and AMI. The dose we use for growth hormone deficiency is 25 micrograms per kilogram per day, and this is based on numerous studies that were performed in the past. A higher dose does not mean a better final height. Growth hormone is an anabolic hormone, as I stated already, and is used in fitness centra for the anabolic effect, not for growth promoting effect. So the dose used here can be very dangerous. Very recently, long-acting preparations are on the market, and Philippe Lizy will discuss this issue later on. What can we expect? All data of all patients treated in Belgium with growth hormone are put into a registry, and from those data, the first-year response was calculated. We have a good and bad responders, as you can see, but again, the earlier, the younger the patient we can start with treatment, the higher the gain in height we can expect. As mentioned before, for the indication of GH deficiency, we start with a dose of 25 micrograms per kilogram per day. Side effects remain rare and are mostly seen at the start of treatment. Side effects we can see are headache, hypertension, slipped capital femoral epiphysis, and worsening of an existing scoliosis. In the beginning, there were some concerns about long-term effects of growth hormone treatment. And in 2012, in a French cohort of a multinational study examining long-term safety of patients treated with GH deficiency during childhood, the risk of mortality was increased. Luckily, this was not confirmed in other studies, but there was an overall advice and agreement not to give doses higher than 50 micrograms per kilogram per day. Dose adjustments are made every 3 months based on IGF-1 levels. How long will we treat our patients? Every time we see them on consultations, we calculate the height velocity, and from the moment height velocity is less than 2 seconds the last 12 months, therapy is stopped. When we treat GH deficient patients, we give back, we replace the growth hormone they do not produce. This is different for the other indications we will discuss. Here, it concerns patients that produce growth hormone, but they do not grow well, and with the administration of growth hormone, their final height will increase. Do we need to treat them? Yes, because it's known from several studies that height is correlated with a better quality of life. So the first indication that we will discuss now is that children small for gestational age of intrauterine growth retardation. Before we can start to treat those patients, they have to 5 criteria. First of all, they have to be more than 4 years of age, and of course their actual height at that age has to be less than 2.5 SD. The height be more than 1 SD deviation and standard deviation less than their target height SDS, and height velocity has to be -0. It means that there is no catch-up growth. And of course, we only can talk about SGA children when they have a birth weight and or birth length that is less than 2 SDA. The dosage we are using for this indication is 35 micrograms per kilogram per day. Another indication are girls with Turner syndrome. You all know Turner syndrome 45XO. They have a very typical clinical presentation. Of course, there is short stature. They have a low hairline. They have web-spaced nipples. They have cubitus valgus, short metacarpal of the 4th finger. So this is the clinical presentation of girls with Turner syndrome. Nowadays, most of the children are diagnosed by amniocentesis antenatally. Here we use a doses of 50 micrograms per kilogram per day. We can expect a gain in final height of about 10 centimeters, but again, the earlier the treatment starts, the better final height. And of course, it's logical, there is also a positive correlation with the height of the parents. A more recent indication are children with Noonan syndrome. It's also called male Turner because in the clinical presentation there is some resemblance with Turner syndrome. They also have this cubitus valgus. They also have some webbed necking. They have a typical coarse facial fissure, and most of the patients with Noonan syndrome have mutations in the PTNPN11 gene on chromosome 12. Also, these patients are treated with a Turner dose of 50 micrograms per kilogram per day. A special indication are children with Prader-Willi syndrome. This is due to a lack of expression of the Prader-Willi region on chromosome 15, but think about children with obesity when you are talking about Prader-Willi, but as you probably know, the image, the presentation initially is totally different. We have babies, small children with hypotonia and failure to thrive, and it's only by growing older that the picture of obesity. They all have endocrine dysfunctions. There can be growth hormone deficiency, but it's not always the case, and they also can be insulin resistant. Here, the treatment is not only to improve their final height, but also we see an increase in lean body mass, a decrease of the fat mass, and an increase in quality of life. The dosage used here is 35 microgram per kilogram per day. Another indication are patients with SHOX deficiency. This is the last indication we will discuss, and SHOX is a very special gene. It's located on the X chromosome, and it causes a syndrome in which the primary manifestation is short stature, but more severe in girls. In addition, they have shorter forearms and lower legs. So, as Daniel discussed, when you see the body proportions, these are children that you can pick up. They have what we call a Madelung deformity of the forearm, as you can see here, and also cubitus volvus. They have a high arched palate and muscular hypertrophy. This is a typical slide showing the role of the SHOX gene. When there is no SHOX gene at all, you have patients with mesomelic dwarfism. When there is one SHOX gene, then you have the typical SHOX patients. These are normal patients. And here, when you have a female with triple X, so they have 3 copies of the SHOX gene, you can have patients. So this demonstrates the role of the SHOX gene in growth. So it's not growth hormone that makes us growing. As Daniel already showed, growth hormone is secreted by the pituitary, but is acting through a receptor on the liver where IGF-1 is produced, and it's mainly IGF-1 that will make the patients growing. So, as discussed earlier, not only we can have problems with growth hormone secretion, but on the whole pathway, there can be problems making a child not growing well. So when the problem is in the IGF-1 molecule, then of course you can have high growth hormone levels, but low IGF-1 levels, and these patients can be treated with Encrelex. As I stated, we can treat patients with growth hormone unless the epiphyses are open. So one can think if it's not a purpose to delay the epiphyseal maturation, so having a bigger therapeutic window for growth. In this context, studies try to use aromatase inhibitors or want to delay the puberty by using decapeptyl agonist medication. But this is not so frequently. Are we dealing with a very big problem? As I told you, all the data of all the patients treated in Belgium are collected in a database. And here you can see in 2022 that in Belgium at that moment more than 1,400 people were treated with growth hormone. And as you see for the specific indications, almost half of them are growth hormone deficient. And the second biggest indication are the people with intrauterine growth retardation. Noonan, Prader-Willi and SHOX and Turner syndrome are rather a small proportion. So what are the take-home messages? Growth hormone treatment is not only for GH deficient patients. We need a correct diagnosis before the start of any treatment, and the earlier we can start, the better final height.